So I'd ask you to take your seat and we'll get the meeting underway. First of all, we're going to go over the consent agenda, and thanks everybody for coming out this evening and joining us for this meeting. I know it's been a rough day for some of us in terms of the issue with the rain in certain areas of the city, so I do wish them all the best going forward, as well as I know our staff were taxed in terms of 311 receiving calls, and they did the best that they were able to do this morning, but I think most of the concerns got handled. So I do want to pass on my thanks to not only our city staff, but also Hydro staff and everybody else that was on the street, from the OPS service to paramedics to fire, that were out there looking after the residents in our community. So thank you to all of them. Having said all that, we will go over the consent agenda. There's no ceremonial activities for this evening. Move on to declaration of pecuniary interest. Oh, sorry, roll call, Madam Chair. Thank you.
Member Chernyshenko?
Présent.
Membre Fleury?
Ici.
Member Kapoor?
Présent.
Member Lakin?
Présent.
Member McKenney?
Present.
Membre Pinel?
Présent.
Vice-présidente Poirier?
Présente.
Chair Kadri?
Present.
Member Kakish?
Present.
Member Taylor?
Here.
Member Tilley?
Present.
You have quorum, Mr. Chair.
Thank you very much, Madam Secretary. And regrets, we have none for this evening. Declaration of pecuniary interest, including the originally arising from prior meetings. Anybody any interest? No? Thank you. Confirmation of minutes. Can we confirm the minutes of meeting of September 18th? Carried. Thank you. Communication. There were 6 communication items have been received and held on file with the Board of Health Secretary, and they're listed on your report. There was a response to inquiry from, I guess, Councillor McKenney or Member McKenney on that list.
Yeah, I just have a couple questions for staff, so if we could hold that, if we could lift it on to the agenda.
Thank you. And with the agreement of the board members, can we move that off the inquiry list and move it onto the agenda? Carried. Thank you. And so we'll come back to that item at the very end of the agenda going forward. Thank you for that. And item number 1, Chair of the Board of Verbal Report. We will hold that. Medical Officer of Health Verbal Report. As usual, we will hold on to that also. Okay. Member Tilley, please, motion to introduce reports.
Be it resolved that the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, the Ontario's Health System Transformation Response to the Minister's Expert Panel Report, the Ottawa Public Health Application to Health Canada for an exemption from the Controlled Drugs and Substances Act Report, the West Nile Virus Activity 2017 Season Report, and the 2018 Ottawa Board of Health Meeting Schedule Report be received and considered, and be it further resolved that the rules of procedure be suspended to receive and table the report titled 2018 Draft Operating Budget for the Ottawa Board of Health.
Thank you very much. Is that carried?
Carried.
Thank you. So coming back to item 1, Chair of the Board of Health Verbal Report we will hold, along with the Medical Officer Health Report number 2. Item number 3, Draft Operating Budget for the Ottawa Board of Health. There is a presentation on that, so we will hold that item. Item number 4, Ontario's Health System Transformation Response to the Minister's Expert Panel Report, and again we will hold that item as there's a presentation on that. Item number 5, Ottawa Public Health Application to Health Canada for an exemption from the Controlled Drug and Substance Abuse Act. There is also a presentation on that, so we'll hold that item. Item number 6, West Nile Virus Activity. And the recommendation here is that the Board of Health for the City of Ottawa Health Unit receive this report for information, and there is a presentation on that, so we will hold that item. And then moving on to information previously distributed. number 7, the Ottawa Board of Health meeting schedule for 2018. Can we carry that item, or anybody have changes? Carried? Thank you. Okay, so moving on to information previously distributed. Is that received? Thank you. Okay, we're back to item number 1, which is my verbal report as the chair. Good evening, and thank you very much for joining us this evening. Tonight, I would like to begin by updating you on some of the exciting work that has been happening at the Ottawa Public Health since we met last month. OPH has been active in the community supporting various events. In September, OPH joined in the Recovery Alley social media campaign, and along with dozens of partners, agencies attended the Recovery Day, Ottawa. The event and campaign, organized by the Community Addiction Peer Support Association, aims to reduce the stigma surrounding addiction and raise awareness about recovery in Ottawa. Thank you to board members McKinney, Fleury, and OPH employees for joining me at the Recovery Day event in person, and to all those who participated in the Recovery Alley social media campaign. Several board members participated in the social media campaign to show support for people in our community recovering. Thank you to members Pinnell, Poirier, and Tilley for supporting the social media campaign. In addition, as many of you know, the Parenting in Ottawa Facebook page continues to be a hub of information sharing where OPH responds to family parenting questions on topics such as breastfeeding, child growth and development, and more. This fall, Councillor Fleury supported the OPH team by filming a number of videos with his newborn son. Congratulations, Councillor Fleury. The video series, which launches later this year, provides parents with skills and how-to videos for bringing their baby homes. That'll come. The videos filmed by the counselor, including content on changing a newborn's diaper and bathing your baby. I'm sure these videos will help to answer frequently asked questions OPH receives from parents, especially new parents. I would like to thank Councillor Fleury, his wife Leah, and their new baby Jacob, who filmed the videos with public health nurse France Venn. Finally, I would also like to congratulate Member Tilley. Member Tilley was the recipient of the Community Service Award at Algonquin College's first ever alumni of the Distinction Award ceremony. The award recognizes former students who have gone on to do great things, both in their careers and in their community. My heartfelt congratulations to you, Member Tilley, and all the best going forward in your work. Thank you, and that concludes my report for this evening. Do we have any questions? Can we receive the report? Thank you. I'll turn the floor over to Dr. Levy for his verbal report.
Many thanks, Chair. Good evening, everyone. Bonsoir. Feels like we were just together, but much has happened since we last met, and as we are meeting again, of course, on traditional Algonquin land, I'm reminded of our discussion last June about promoting reconciliation and advancing Indigenous health equity in Ottawa. And you'll see in the budget documents before you tonight that we've certainly kept that notion front and center. We're going to continue keeping the goals of reconciliation active and alive in our mind and in our organization as we develop and implement our programs and partnerships. Tonight, we have a report before you following your approval of the last meeting that Ottawa Public Health began operating a temporary supervised injection service. And you'll recall, of course, that your direction was that we bring a report with recommendations for a more permanent solution early next year. And as you now know, we did, in fact, subsequent to our board meeting, receive the required approvals from Health Canada and a funding commitment from the province for the plan that we had put before you, a 4-month plan. And we began services at Clarence Street on September the 26th. The operations then are not mature enough really to report on, but I can tell you I've visited the site several times, and I really can assure you that what is happening there is professionalism and commitment to service that I'm extremely proud of, and I know that you too would be proud of the employees and the team members. They're doing a very good job. And of course, any of you that wants to drop in there and see this new service up close is welcome to do that. We will report as planned on progress at the next, sorry, not at the next meeting, but at the first board meeting in 2018. But the report before you tonight I'm bringing is an intervening report that I hadn't anticipated needing to bring. It addresses the technicality that Health Canada, in the wording of their exemption, is allowing their exemption that allows us to operate the site, is allowing the service at Clarence Street only until the service at Sandy Hill begins operating. Because we're not aware of what that timeline specifically is, this exemption may in fact expire before the board meeting in early 2018. So the report tonight asks for permission to make the technical changes to the documentation that would be required to ensure that we can in fact continue to operate as the policy direction that we received enabled us. In the meantime, I do want to thank all of our local partners who are working to meet the growing harm reduction and other treatment needs in Ottawa, and also members of the media who, for the most part at least, have been, from my point of view, sensitively and professionally describing the health challenges that are facing drug users in this community every day. I will reiterate that the services that we provide at Ottawa Public Health are not the whole picture. We have to work with partners throughout the health system, the social services sector, law enforcement and others, and especially housing, because the challenges are complex and no single agency has the full mandate or resource capacity to address these issues. So the partnerships are important. On a completely different issue, but one also that I'm very proud of and I think we can celebrate, is that I'm now in a position to update you on the audit of our emergency preparedness and response program. We brought, in February of this year, we brought to your attention that the Office of the Auditor General had proposed to the City of Ottawa and to City Council that it include an audit of emergency preparedness and response for health services in its 2017 plan. And last week I was formally advised that the auditor has concluded that our program meets or exceeds relevant requirements and standards in all key areas. And because of that, no further audit-related work on the emergency management program at OPH is planned at this time. It may seem trivial, but from my point of view, this provides further reassurance and should be further reassuring people who are with us tonight. Mike Ferguson, Esther Mogadam, just to mention two, were very closely involved in that program and in the audit work that went on. So my personal kudos to them and thanks to them. It is, I think, a tremendous and positive reflection also on the professionalism and commitment of the whole organization and the employees. So on that, I'll also add the comment, of course, that at this time of the year, citizens in Ottawa begin receiving messaging about flu vaccine. It is the flu season. Pharmacies and physicians' offices in Ottawa now have vaccine. We encourage people to get immunized. It is the best way to be protected against the flu virus, though, of course, washing hands and sneezing into the sleeve can never be overrated, or underestimated, rather. Flu is a very serious and unpleasant illness. Ottawa citizens started getting flu vaccine through our own clinics this weekend. You'll know from previous discussions that as more and more people are getting their vaccines from more and more pharmacies, we've been able to make our own clinics ever more efficient and been able to redirect our staff resources to high-risk and harder-to-reach people, including especially people in shelters, newcomers to Ottawa, specifically for vaccines, but also there are new requirements that we've discussed before regarding providing education to parents who are reluctant to vaccinate their children. And so we think we're able to use the resources ever more effectively and efficiently. We are still running community clinics, as I've just mentioned. This weekend we had really excellent interest in our first clinic of the season. I don't know if any of you were able to drop in there. I dropped in early on Saturday. The lines were long. There was robust interest. The community obviously cares. We had reduced our hours, but we still vaccinated over 700 people in less than 3 hours, I guess just in 3 hours. So we're proud of those numbers and proud of the fact that we're still continuing to meet community need and client expectation. So with those examples in mind, I also do want to mention to you that since we last met, I did complete the organizational alignment exercise that I've told you about previously. And in this regard, specifically, also with us tonight, I'm very pleased to be able to welcome back to Ottawa Public Health Ms. Sherry Beadle. Sherry will be known to many of you. She spent more than 25 years with Ottawa Public Health in the field as a public health inspector and a public health leader. And she's joining us now as our new manager of environmental health. Coming back to us after a stint at the Economic Development Office at the city. So I'm very excited, and we look forward to Sherry's contributions as she brings those new skills and perspectives to the team. The alignment exercise, you'll remember, was undertaken to prepare for the ministry's new requirements of boards of health. And it was done with a sensitivity to Ottawa's health programming needs and the health needs of the community in mind. But in the end, we did conclude that we needed to change things up a fair bit. And this month, many of our employees have started in new roles based on operational and language needs, professional skills and designations, and of course their own interests. And I'm confident that the new structure will help us to be agile and responsive to the new realities. Talking of those new realities, I can tell you, as I know some of you are aware through other roles that you have, that the province's activist health system transformation agenda is continuing apace. The Ministry of Health and Long-Term Care is receiving feedback now on the Minister's Expert Panel on Public Health. That report is before you this evening, and in our report we provide an analysis of the implications of the report and recommendations to the Ministry. Meanwhile, late last week the province invited MOHs and board chairs to hold the date for a summit in mid-November, I guess, and we're eagerly awaiting news as to what the agenda is, but speculation is that it's to possibly launch the new standards officially or to advise of their decision regarding the next steps on the expert panel. Also last week, the Ministry informed us of proposed amendments to several regulations under the Health Protection and Promotion Act, so they really do seem to be gathering ahead of steam to get things done. They've invited us to provide feedback on these proposed amendments. There are at least 11 regulatory amendments that are on the table. They want that feedback by November the 8th. The majority of the regulatory changes suggested are in the areas of environmental health, but some are also in the communicable disease area, so we'll have to digest that, and given the very short timelines, our staff will review those changes, their implications. I'll respond to the province by the prescribed deadline as needed, and I'll of course keep you apprised of any pertinent developments. So you can sense that the pace of the material that comes in from the ministry and the need for us to adapt and respond, internalize, adapt, and respond is pretty substantial. We do try and meet the deadlines. I apologize again that the inquiry that was put before us in June was deferred from the last meeting, but we're pleased to be able to talk about it tonight. But that's the kind of context in terms of how we have competing deadlines. So I do thank you for your patience as we grapple with these things, and I hope that these comments help keep you informed of the flavor of what we're doing and the key elements of the things you're interested in. That concludes the comments I wanted to make tonight, and of course, Mr. Chair, members, I'm always happy to take questions. Merci beaucoup.
Thank you very much, Dr. Levy, for your report. And since you mentioned vaccination in your presentation, I did have a question from a resident this morning that was portrayed to me about the resources that we're spending on flu clinics in the city and how we are working towards reducing those resources in light of or in lieu of what the pharmacies are doing and private offices are able to do now that weren't able to do, let's say, a couple of years ago. So if you could respond to that, please.
Yes, sure. So the Universal Immunization Influenza Program in Ontario was introduced probably about 15 years ago, and for the first 10 or 12 years, the vaccine was delivered by alternate providers that were restricted pretty much to physicians in the community, to other hospitals and healthcare providers, and public health clinics. Historically, until about 3 or 4 years ago, we were distributing roughly 400,000 flu shots into the community, and we delivered through public health programming about 10% of those, so probably about 40,000. And we did that with community flu clinics, and those clinics were designed and promoted as a service to residents. About 4 years ago, the province allowed pharmacies to deliver influenza vaccine, and we've seen a slow and progressive increase in the number of pharmacies that have come on board with that program, and concomitantly a very reassuring and nice rise in the number of people who get their vaccine from pharmacies. There are still several restrictions. Pharmacies are not able to provide vaccine to children under 5. So we're concerned about needing to maintain an ability and a capacity within our own staff and services to vaccinate children under 5, especially children who don't have access to a family physician of their own. So the net effect, though, is over the last 3 or 4 years, we've gone down from roughly 40,000, a little under 40,000 vaccines directly delivered by Ottawa public health staff at community clinics to, I think, about 7,000 last year. I'll look at Esther and Gillian, and Geneviève's nodding. So about 7,000 over. So it's a nice steep decline. And what we do is we try and ensure that we're still running clinics in areas of need. So that's areas where there's high uptake and low pharmacy coverage. And we've been able to redirect the resources that we're saving to do more outreach into the higher risk and harder to reach communities, especially shelters and clinics for newcomers. So that's the essence of it. Saturday's clinic, I think, saw 700 in 3 hours, 720 in 3 hours, 12 nurses. So we're running about 10 times faster than we were able to achieve during H1N1, and I think that per head, the per head cost is probably under $10, which is probably the cheapest service that the government gets for its healthcare dollar anywhere in the province.
Thank you very much, Israel, for your report and for answering the question. In terms of, just to let everybody else in the room know, this past weekend on Sunday, actually, Member Taylor, Israel, and myself did our flu vaccination at a local pharmacy in the West End. So again, showing, and we talked to the local pharmacist in terms of number of calls that they were receiving. And it was quite an impressive number that she mentioned to us. I think it was up to 20 a day that she was receiving and or inoculating. So which is a great number to have going forward, and other pharmacies included. So open for question from the members. Madame Poirier.
Thank you, Chair Kadri. I just had a quick question more out of personal interest, because recently my doctor recommended the shingles vaccine, and in terms of under the title of immunization, do you often get calls, and does the department get involved in promoting those other vaccines?
Thanks very much. So we do, to both questions. One of the biggest challenges, I'm sorry, someone thinks that I should be answering the phone right now. It's probably a vaccine question. One of the biggest challenges that we have is we provide professional advice about all vaccines that are approved by the National Advisory Committee for Immunization. But we only distribute and more aggressively promote the vaccines that are part of the publicly funded program. So the shingles vaccine now is the varicella, the zoster vaccine is part of that program, and we do promote it. We do get a lot of inquiries for it. We also have increasingly received signals from the province that the provincial vaccine, they call it Immunization 2020, the provincial vaccine program is something that they're particularly interested in boards of health and health units promoting. So we've developed our own multi-year strategy to align with that strategy, which does include adults and the promotion of all vaccines to adults. Thank you.
Okay, moving on to item number 3, draft operating budget for the Ottawa Board of Health. I'd like to invite Lou Flavaria as well as Brenda Gordon to the table to present the operating budget for 2018.
Good evening. Tonight I'm joined here at the table by Brenda Gordon to my far right. Brenda joins us from the Finance Department, and Jane Dare. Tonight, as we table the 2018 budget report, we'll cover a very brief overview of our mandate, revenue sources, and funding context. This budget reflects our best information and judgment on emerging health issues, identifying efficiencies, reinvesting in community needs, and maximizing our funders' investment. This presentation will also provide an overview of 2018 budget changes, budget timelines, and next steps. I would like to begin by reminding you of our mandate. Ontario's Health Protection and Promotion Act provides the legislative mandate for boards of health and the broad array of health services we deliver. In addition, there are other provincial statutes that identify specific duties for the boards of health and medical officers of health, including Immunization of Schools Pupils Act, Safe Drinking Water Act, and Smoke-Free Ontario Act. Under the HPPA, there are 21 regulations that must be adhered to that govern areas of service such as food safety, rabies, and communicable disease control. Also under the authority of the HPPA, the Ministry of Health and Long-Term Care publishes the Ontario Public Health Standards, which are the minimum standards and expectations for the provision of public health services to which all boards of health must comply. Lastly, as a condition of funding, we keep in mind the ministry establishes an annual accountability agreement with boards of health that includes performance expectations and data reporting requirements based on the standards that we measure and report to you and the province throughout the year. The context under which we work continues to be complex and changing. As you're well aware, and as Israel mentioned, the ministry is conducting a full review of the Ontario Public Health Standards, as well as the Public Health Funding Accountability Agreement, and rebranding this as the Ontario Standards for Public Health Programs and Services. We have been advised that these new provincial standards and accountability requirements will be established for 2018, and we'll keep you appraised as details become available. In addition to our legislative requirements, the budget was also developed with guidance of our OPH strategic framework and strategic plan. As we look to continuous improvement, working to reduce health disparities, using evidence-informed decision-making, and working with partners and clients, it informs our choices about how we use our resources to best address local public health risks and community need. So in setting the priorities for 2018, teams across the organization considered emerging health risks, community needs, strategic priorities, and compliance with OPHS and achieving performance indicators. The draft budget seeks to maximize revenues on our base through one-time grants as part of our provincial grant submission early in 2018, and then as opportunities arise during the year. The funding for public health services consists of several categories. The majority of our funding supports the provision for provincially regulated public health programs on a cost-shared formula where we receive provincial funding for 75% of the cost of the regulated public health programs under the HPPA. Secondly, there's cost-share programs, and they are funded at 100% by the province. There's also programs funded at 100% by the city, and they are investments that Council has supported as priorities. Lastly, there's a portion that involves recovery payments from services such as dental and fees for service. With all that in mind, we are presenting a balanced budget of $60.1 million. It aligns with city guidelines and includes a request to the province of $305,000 over the approved 2017 funding level for cost-share programs and assumes that there will be a zero increase on 100% programs and services. This next slide provides a high-level summary of the 2018 budget changes. Maintaining services, which includes collective agreement cost of living increases, is a principal expense, the principal expense change, and those costs are offset by municipal and potential provincial funding increases. This next slide presents the budget timeline. After tonight's meeting, the Board of Health budget will be tabled with City Council on November the 8th, and then returned to the Board of Health on December 11th for public delegations and approval. Public consultation occurs from this point forward to the 11th of December meeting, and inquiries can be directed to Diane Blais. In summary, we are presenting a balanced budget with a slight increase in order to maintain operations. We welcome any questions at this time.
Thank you very much for your presentation. Now, this evening, we're entertaining any high-level questions from the board members. If you have any, the floor is open for those. Member Lakin, please.
Yeah. Thank you for that overview. Just a theoretical question, given that the new standards aren't out, but they're anticipated. Have there been any scenarios that have allowed you to model cost implications for the budget in view of expectations of changes in standards? Have you done any modeling around that yet?
Not at this point. We're in discussion with the ministry in terms of those standards, and those discussions are ongoing. And we should have more clarification as we move closer into November, December, and early in the year.
If the perspective of those in the field that have seen the drafts is that cost neutrality is going to come with some significant challenge in implementation.
Member Taylor?
Thanks very much, Mr. Chair. Just a quick, I guess, high level in terms of timing. Dr. Levy, on the summary, it notes that on the variances, there's a $910,000 variance. It says unexpected one-time cost overruns from the spring flood and opioid response, offset by anticipated provincial revenue result in a break-even year-end forecast. So this is anticipated provincial money, but do we have any sense as to whether we'll know for sure from the province by the time we get to our final budget if it's materialized, or are we going to be approving a budget with an anticipated receivable?
Yes, at this point, we've put in the request for the additional funding, but we haven't heard back from the ministry. Typically, this type of information would come back through our normal annual grant request. So prior to the 11th of December meeting, we should have some information one way or another from the province on that.
Member Chernyshenko?
Thank you very much, Mr. Chair. Keeping in mind that this is high level, it's always trying to judge that line between asking a meaningful question and getting too detailed for the presentation of a budget. I'm seeing before me what looks like a steady as she goes, putting aside for a moment, waiting to get those signals from the province, which will be quite significant. But otherwise, I'm not hearing any major cuts to anything, any major new spending initiatives. I guess is that a fair characterization? Is by a nod, I suppose, or an answer? Is that a fair? Yes, that seemed to be the one area. Well, two areas really. One I will key on in particular, since of course the opioid crisis is one that's got a significant amount of attention, and many people have been focusing on. But all we have to do is look at the rain that fell the last 36 hours or so, and the flooding, and the bizarre weather that we've had. It's no surprise to anyone. I'm watching very closely climate change and the adaptation impacts that we'll deal with mitigation through the committee I chair, but the adaptation approach here, I'm seeing that increases in Lyme disease, increases in West Nile, spending related to flooding, for example. How would you characterize the board's approach or planning for possible unanticipated, or how do I phrase that? How are we anticipating something that's hard to anticipate? How would we respond to a surge beyond perhaps a steady growth in some of those things?
Thanks very much. It's a very insightful question, and it speaks to some of the issues we've been grappling with, not only through the budget process, but also through the alignment. Others around this table, Councillor Taylor, several times has raised the issue of the new normal and some of the fact that last year we were in enhanced response situations, probably a third of the year. This year I think we've probably exceeded that. And so we've approached that through a number of different strategies, including trying to work on efficiencies around some of our staff time schedules, different types of contracts from staff that we've hired in, and generally speaking, an adaptive workforce with more flexibility and ability to move people and redeploy people in response to emerging issues that happened during the year. The longer-term strategic issues that we have to grapple with in terms of these more subtle trends that create pressure are things that we really end up, to some degree, managing to the bottom line. So the proposed budget takes many things into account in terms of the assumptions, and then during the year, we do in-year adjustments to and bring those forward to you. One of the anticipated guidelines of the new standards explicitly will address climate change, we believe, and will, the best guess is we'll be required as a board to bring forward plans, and the plans will need to be reviewed and accepted by the ministry. The budget document, being an important policy document, will have sister documents looking at things like climate change plans that are multi-year plans that that boards of health will likely have to produce in the future. So I think it comes about through those various angles. The only other point that I'd just make in response to that question is that I think the observation that this is a steady-as-she-goes budget is quite right. And it reflects. I always have a bit of a dilemma when I come before you with a board with a proposed budget. We could come forward with a budget that is profoundly challenging in terms of identifying needs in the community that we think we can do something about if there's resourcing for that. But we come at it from a different angle. We make our best assessment as to what the funders are likely to accept as an approach, and we manage our recommendations to the assumed budget disbursement. There isn't probably that much of a discrepancy, but it saves the challenge of having to really haggle down a wish list and sit and discern whether or not we think that specific programming in specific high needs area is a good idea. I'm always going to tell you it is, and our funders will always tell you that it might be too unreasonable and ask for their taste, and then you as a board are caught in that. So we come forward philosophically with a balanced budget. The challenge this year that was very significant on that front was opioids. Really we've got a steady-as-she-goes budget, but we also know that the province has announced a pot of money for opioids. That pot is supposed to be that investment is supposed to go to the full range of long-term and short-term issues that will help address the opioid challenges and addiction challenges in the community. Public health is a very small part of that. We expect a small part of the global budget, but certainly what's before you assumes that there will be more to address the opioid challenges that we're likely to see in 2018. What's before you does not include an increase for that pressure.
Okay. Thank you. I certainly look forward to more detail on particularly the climate front as well as we certainly will want to on opioid. But yeah, it's interesting, if I might just close with the comment that obviously your philosophical or political approach you've taken is let's budget for what we expect to be available, as opposed to let's create a wish list budget of all the things that we think ought to be done or could be done. And given that Council has itself voted for a 2% target, I suppose that's a politically wise thing to do. So thank you.
Just to that comment, Councillor, keep in mind that majority of our budget comes from the province in terms of dollars coming forward. So, anyways, having said that, anybody else have any questions or comments? Seeing none, can we pass the recommendation of the report, which are number 1, receive and table the 2018 draft operating budget for the Ottawa Board of Health, and number 2, direct staff to forward the 2018 draft operating budget for the Ottawa Board of Health to Ottawa City Council on November the 8th, 2017, as part of the City Council's tabling of the City of Ottawa 2018 operating budget and capital budget. Is that carried? Carried. Thank you very much. Thank you, Lou and Brenda, for your presentations. Okay, moving forward, item number 4, Ontario's health system transformation response to the Minister's expert panel report. And we do have a presentation on that. Good evening, ladies, and if you want to introduce yourself to the committee, that would be great, and look forward to the presentation. Thank you.
Good evening. Hello, my name is Inga Rosendahl, and I'm in the Community and Partner Engagement Branch and have been monitoring this file on health system transformation as it's evolved.
Kara Etchus, Deputy Medical Officer of Health. Merci.
Okay, so our presentation today is to give you a brief overview of the history of the health system transformation, which you would have also received updates for in previous board meetings. And we're also here today to give you an overview and assessment of the most recent report, the Minister's Expert Panel on Public Health within an Integrated Health System. As I'll review towards the end of the presentation, we recommend that you, through the chair, make a submission on the expert panel consultation, which is actually due to the minister tomorrow. So first, just before we get to the expert panel, I did want to provide you with a bit of an overview of the history, as there have been quite a few moving parts to health system transformation. The Ministry of Health and Long-Term Care began to signal its intentions to transform the health system in early 2015 with their report, Patients First, Action Plan for Healthcare. And then, as you see up on your screen, in December of 2015, with Patients First, a proposal to strengthen patient-centered care in Ontario. The province has a vision for change that's focused on meeting individual client needs. And as you can see up on the screen, those are some of the key proposals that they included in their Patients First discussion paper. As part of this, the ministry's flagged that LHINs, primary care, and public health need to be more aligned and integrated. So we've been giving you updates and provided input into ministry consultations as opportunities have arisen. And we have flagged that the patient-centered and health services focus does have the potential to run into friction with the population focus mandated for us in public health. So as we've outlined in previous reports, the Patients First discussion paper set the stage for a number of potential changes to the public health landscape. And we've seen the release of some very important documents that feed into the changes. First, we have Bill 41, Patients First Act 2016, which enacts many of the recommendations from Patients First discussion paper. It strengthens integration of public health and health service delivery, and part of this is through requiring that LHINs formally engage with medical officers of health. So you may also remember that in the Patients First discussion paper, the ministry proposed that public health funding would flow through the LHINs, but Alpha did oppose that and the ministry listened. And because of that, our funding does continue to flow through the Ministry of Health and Long-Term Care as opposed to the LHINs. And we've also, as you just heard from Lou, about the public health standards modernization, with the ministry releasing a draft consultation version earlier this year. So it's anticipated that they'll take effect in January of 2018 and will result in changes impacting some programs and services. So just to go back to the minister's broader health system transformation work, in support of implementing the ministry's transformation agenda, they set up a series of work streams. One of them was a public health work stream. This work stream was established to better understand how to operationalize LHIN and public health collaboration. So their public health work stream report, that was the culmination of their work, outlined a framework on how to achieve this collaboration. They basically suggested there's three main potential areas for collaboration, as you see up on the screen, around population health assessment. I believe you would have received a memo as an example of how we're doing this locally last Friday, joint planning for health services, and population health initiatives. So finally, and the one that the report before you today provides a focus on, we have the Minister's Expert Panel on Public Health, which was tasked with providing advice on how public health should be structured, organized, and governed. The panel was asked for recommendations that would improve health unit capacity and equity across Ontario. And they're also mandated to support integration of public health with a broader health system and LHINs. Principles guiding their work include making sure that public health maintains an independent voice and that public health continues to have strong relationships with municipal governments and local organizations. So the report before you today is about responding to the ministry on the expert panel's recommendations. So just to go over some of their key recommendations, they do fall within those structure, organization, and governance areas. In terms of structure, the panel, the recommendations are quite significant in that the panel recommends going from 36 public health units, local public health units, to 14 regional health entities. These entities would be aligned with LHIN boundaries as opposed to being organized around municipal boundaries. So in our Champlain region, for instance, a regional board of health would include us at OPH, or would include the OPH area, Eastern Ontario Health Unit, parts of Renfrew County and District Health Unit, and Leeds, Grenville, and Lanark District Health Unit. So quite a substantially large geographic area. Then we have organizational changes. Each regional public health entity would be led by a CEO who would report to the Regional Board of Health. And then there'd also be a regional MOH who would report to a CEO. In addition, there would be local public health service delivery areas. So each of these regional entities would be subdivided into these areas with a local MOH who reports to the regional MOH. And then finally, we have governance proposals, proposed governance changes. The panel recommends moving from a regional board of health that would have 12 to 15 members with municipal representation, provincial appointees, and citizen members. So of all of the health system transformation documents that I've just reviewed, it's our interpretation that this expert panel report has by far the most significant impacts on public health. If implemented, they'd fundamentally change the Ontario public health landscape. We do welcome looking at ways to build capacity of the public health sector to inform health system planning. And having public health resources spread more equitably across the province would certainly be positive. But there may be some important unintended consequences that may jeopardize the principles driving the expert panel report. We recommend that some key considerations could help mitigate some of these potential negative impacts. The recommendations for the minister before you tonight and up on the slide align with feedback from other groups, including ALPHA, the Council of Ontario Medical Officers of Health, and the Association of Municipalities of Ontario, as well as other public health units. So in terms of the first consideration is really to protect our upstream approach in public health from being diluted due to being more closely aligned with the healthcare sector and potentially shifted to more visible primary care services like the treatment of disease. The second is recommending that we maintain municipal boundaries so that we can keep working effectively with our municipal partners, both within and outside government. So much of what we do in influencing the determinants of health is thanks to the strong and rich relationships that we have with our municipal partners. Third, consider the governance implications, because with only 14 regional boards of health across the province, we'll have less local representation in public health. And the new Board of Health would have very large and diverse communities to oversee. Local perspectives and public health decision-making could be diluted. Fourth, recognize the disentanglement costs for moving away from the current administrative structures to the new ones, which would be quite significant. There would be large impacts on health units such as OPH that are embedded within municipal infrastructure. And fifth, take a deeper look at the implications of the recommendations. Might there be other options that would improve our capacity without restructuring the public health landscape? So overall, we recommend that the ministry wait until the new standards are implemented and that the promising practices from the public health workstream are explored before considering implementing the expert panel recommendations, and that further analysis is needed before we move forward. Thank you.
Questions? I've got Member Fleury for the first questioner.
Chair, I don't have questions. I have comments. Is it appropriate to make comments on the issue?
Sure, if you want to. That's fine.
So I know the letter is due tomorrow, and I'm confident that we can send something in. I think from a board perspective, and this is my feeling towards this, is we have to take a longer term view, which is at some point, whoever's elected provincially might look at what is the purpose of the LHIN. Other governments or even the current government could also look at what about doing regional housing as a review. We don't know where the national housing policy will land. We know in the medium to longer term landscape that how cities manage solid waste. Right now we only have the residential side, we don't have the industrial, commercial, institutional side, might also factor into all of this. So I would prefer if, instead of trying to answer bullet per bullet, we would give a profile of what we see as an issue and why we believe that Ottawa Public Health, within its current jurisdiction format, has a strong purpose. And in my mind, I would go to, and I would steal the map that the mayor's office has in terms of how big of a land space we have when we consider that we're Montreal, Toronto, Edmonton, Vancouver, and Calgary, plus we still have 100 square kilometers. I think that highlights the problem right then and there is we're not in Southern Ontario where municipalities who have strong governance, strong councils can carry through broader decisions for an area. Outside of Ottawa, like, no offense to smaller municipalities, they just don't have the type of issues. And I mean, we're dealing with the opioid crisis. How would we deal with that, you know, from Brockville to Hawkesbury to Cornwall to the smaller municipalities? So in my mind, although I do, you know, and I do think it's important to bring the context to not be thrown out in terms of procedural response, I would prefer if we set out why Ottawa is unique as a big city in the province of Ontario, and for that basis would ideally remain as an existing structure. It's not a perfect structure. I'm sure Israel and his team would love to have additional funding, additional authorities, and additional oversight of certain elements. Perhaps even additional coordination if you look at some of the health and social services partners. But in this context of this review, we are at risk. Because if tomorrow, it's not about having us govern and making decisions and reviewing budgets. That's very meaningful. But it's a broader implication of, you know, what's our ability to start looking at public health matters in a smaller municipalities in and around our capital city. So for me, that's you know, and I don't know if I can get a staff comment on that. Dr. Levy maybe on that matter, because that to me goes to the core of why we believe there's an issue in changing our governance structure.
Thank you, Member Fleury, and I do agree with you, but I have let Israel respond to it first, so go forward.
Yeah, thank you very much. I couldn't have said it better. I think you've highlighted a number of issues that at the staff level we've observed and we believe, not just that we'd like more money, but in all seriousness that there's a lot of integration with the municipal partners that we enjoy in Ontario that other health units in the rest of the country do not enjoy. And this is something that's treasured in the Ontario public health system, those of us in the frontline practitioner area. And we'd like to be sure that whatever reforms are brought in will actually build on that and leverage our ability to partner with the housing sector, with other local government entities that impact health. Transportation planning, Parks and Rec, it really is everyone, and we can only achieve that if we're integrated. So the risk to that integration is something we see as profound. We have acknowledged, not all of us in the MOH community, but several of us have acknowledged that there may be something good in some of these proposals. Potential to influence the health sector. The health sector isn't the major determinant of health, notwithstanding people's perceptions that sometimes that it is. But we have almost no potential to influence it now, so we would have more potential, so that's a good thing. Economies of scale is a good thing. From the ministry's perspective, probably there's some risk management of governance, governance scandal in smaller health units that they've probably got their eye on. We don't believe that's an issue here in Ottawa at all. So there are some pros and cons. I think the kinds of things you've suggested tonight are easily things we could try and capture in an introductory paragraph.
Thank you for that, Dr. Member Poirier.
Thank you, Mr. Chair. I would just make the comment that it almost sounds like a solution looking for a problem in the sense that we're talking about restructuring without spending enough time on looking at the options and what it is that we're trying to fix or improve. So I certainly support the notion of not resisting change, but rather saying, let's be part of the change and really do a deep dive on what it is we're trying to fix. And then that will then, I think, result in some options that might be feasible.
Thank you very much, Member Poirier. Member Taylor, please.
Thanks very much, Mr. Chair, and certainly having been involved on the AMO side of the table, chairing the task force, we were the architect of the AMO response, and so it's not surprising that I'm speaking today both in support of our report here, but also the general direction that all of the agencies have taken, Alpha and AMO and the medical officers of health among them. This is a pretty dry subject, and it seemed to just kind of float along and sneak along and not really generated a lot of public interest out there. But the more that you really dig into it and you start to understand the potential ramifications for public health and public health delivery to residents in Ontario, it's reasonably profound. Member Fleury spoke to the size and the uniqueness of our geographic realities, and I would argue that that's both here in Ottawa as it is with our friends in Eastern Ontario and Renfrew and you name it. And I've met with them and they argue the exact same thing. They say that they have unique public health needs in their community that they are best positioned to address more locally than if we had an office somewhere. I don't know where it would be, in Ottawa tweeting at Renfrew or Renfrew trying to convey messaging to downtown Ottawa. So that certainly is worth investigation. The integration part, I think, is something that is really unclear to a lot of people in communities like Ottawa, where we have a fully integrated or fully independent health unit, but one that's still integrated with the city government. We're blessed to be in a situation where if we look at something like a drinking water issue where we need boots on the ground to go and knock on doors, Dr. Levy's in a position where he is fulsomely part of the city's management team. He can pick up the phone and call a general manager from Public Works or another shop in the city and say, I need some help, and they're very quick to respond, and vice versa. That would not be the case if the health unit was some standalone agency like the LHIN. That's not to say that we wouldn't help, but you're introducing a lot more barriers where they need not be. Governance, I think, Member Poirier touched on governance quite nicely. It's not just the concern about the composition of the future board, although embedded within there for my colleagues on this board who are municipal councillors, it's very clear that they wish to de-emphasize the position of municipal councillors on these boards, anticipated future boards. And our argument is being a municipal councillor is a core competence in and of itself. But that doesn't seem to have come through in the expert panel report. And the concept of bringing public health into an organization like the LHIN, if that were to be the case, there is anybody here remember the Ministry of Health Promotion? There is a real danger that with the compelling and very real needs that we have in primary health care delivery, that if we bring public health within that fence, then very quickly its allocations are going to get absorbed into spending on the very real health needs that present in our communities. And that leaves very, very little money, effort, or attention spent then on prevention or promotion or protection of health. It all goes into emergency, which is the opposite direction than we're trying to go in other areas, like Member Fleury mentioned the housing file. We're trying to go in the opposite direction, do more prevention and diversion, not more emergency care. Two more things I just wanted to mention. One is the funding contribution level. Notionally, right now, the theoretical benchmark is that municipalities should be contributing 25% to programs and the province should be funding 75% of programs. In reality, if you look at an Ontario average, municipalities are funding 38%. So we're funding in excess of where we quote-unquote should be, because we recognize that there's community need that we need to address. I am not entirely sure that the City of Ottawa or the Town of Renfrew, their councils would vote to send more money than they had to if they knew that those dollars could be deployed in another municipality. And that, I don't believe, is short-sighted. They would simply be saying, look, we're torn between a global public health good and being good custodians of our tax dollars in our municipality. And the last point I'll make is I'll come back to Member Poirier. She said it's a solution looking for a problem. One of the things we struggled with at AMO was, what problem are you trying to solve? And that was never fully articulated to us, and still has yet to be fully articulated to us by the ministry. And we asked. We said, is it financial? Is it operational? Is it organizational? Is it just easier to deal with fewer health units than it is to deal with more? But they really have never compellingly answered that question. And so until we get to a point where we understand what it is that they're trying to solve, it makes it very, very hard for us to partner on the solutions. So I am in full support today of our public health motion that's here before us in this report, and certainly I think the chair is interested as well in trying to work with our council colleagues to see if there's an appetite at our council level to take this a little further. Thank you very much, Mr. Chair.
Thank you very much, Member Taylor, and we will come back to that item about the council members in terms of our city council in a few minutes. Coming back to Member Kapoor, please.
Thank you, Chair. I concur with the report, and I can agree with the comments I've heard. I'm noting that in some of the communications we've received, the language is even stronger. Councillor Taylor asked, what problem are you trying to solve? I noticed that Peterborough's response says the recommendations in this section feel to us like using an atomic bomb to blow up a mosquito. Very colorful, strong language, and I'm seeing a resonance between what we're saying and what Peterborough has said and what even Chatham-Kent is saying. So it's not just from us in a large urban center, but small urban, and as Chatham-Kent refers to itself, a rural community. We're seeing this similar concerns widespread. My question to Dr. Levy was, I'm not recommending we reproduce Peterborough's quote. It seems to me here that we have a lot of support around the board for the language in our report to be clearer, crisper, and even more stronger. I know it only gives 12 hours to submit that, but I'm not sure, Dr. Levy, if we want to strengthen that. I think there's support from the board of strengthening the language, or whether you want to leave it the way we have it and they can see the range of language from us versus Peterborough versus the other units that have also shared this. My only other comment in response to Councillor Taylor's comment is, what problem are they solving? And it appears to me that there's a solving of an ideological problem, which is we invested so much in the lens. How do we need to force everything to go through the lens to make that, to keep the viability of that, or to keep that from being changed. And unfortunately, I haven't seen any stronger arguments than that.
Want a response, Doctor?
I'm not sure how to respond, but I'll say that the MOH in Peterborough is much more colorful than I on a number of subjects. We were sensitive as we've managed this file over a period of time. I guess probably the recommendations that come before you are framed and phrased the way they are because of two fundamental themes. One is the culture, the tenor of most of our recommendations, as you know, is measured, and we try to be non-alarmist. But so we believe that we've made essentially the same point, with less colorful language. So that's perhaps one piece to it. The other piece is a sensitivity that, from two different points of view, that the language that we put forward should be measured, and that the language that we recommend to you should be measured. And it should be measured for two reasons, from my perspective. One is, as I've already alluded to, I do think that there are potential advantages in some of what's on the table. We're the first to raise problems with the structure and organization and governance. We being MOHs, field practitioners, when things aren't going well. And one of the challenges we've had in our dialogue over time has been that we really don't know what problem they're trying to fix. But if we were the ones who had put forward the articulation of the problems, there are elements of the proposals that actually could be supported and built upon, I think, in a constructive way. So we were sensitive to that. We're sensitive to the fact that although I think the vast majority of field practitioners and boards of health are consistent with the sentiment that's before you tonight, there are some who see the need for more radical change. And so, again, we didn't want to join a cacophony without acknowledging that there's a different perspective. And the third was just pragmatism. They are still our major funders. They carry a big stick. And we believe that there's more to be gained over the long term by a more equanimitous and measured relationship and dialogue with them.
Thank you very much, Doctor. Anybody else? Member Kakish?
Thank you, Chair, and I think, Doctor, you addressed some of my, what I was going to ask in terms of your optimism with them potentially being interested in collaborating with us. But, when I look at the geographic boundaries and how specific they are and how sort of drastic they are in terms of amalgamating the regions, it seems like they have a specific path forward in mind. And so is this really them consulting with the various local health agencies, or do you think that there are some things where they're not able to negotiate or be flexible on?
So all of the communications that have come to us have come from the administrative level of government, and they've been extremely careful to observe that no policy recommendations have been made to the minister or to cabinet, that the work that they've conducted has been within the general frame and guidance of a review of public health within the context of health system transformation, but that the report before us is merely an expert panel's set of recommendations to the minister, and that the ministry still needs to make recommendations to the minister before any further policy decisions are contemplated. They've also acknowledged, they being senior bureaucrats within the Ministry of Health and Long-Term Care, have acknowledged that implementation was not a part of the considerations, and that there are implementation considerations that would have to be brought to bear, and that a consultation would need to be done in that regard. And what isn't completely clear is whether this comment period that then opened up sort of on a Friday afternoon in the summer is in fact the consultation, or whether something more meaningful would follow if decisions towards implementation were made.
I'm interested in hearing your sort of perspective on your biggest concern in terms of the amalgamation of these health agencies, other than the fact that your job may change or may be at risk. But in terms of that, I know staff spoke about it, but for you as our chief officer here today, I mean, what is the biggest concern for you in terms of moving forward with some of these changes?
I think thank you very much for that. I think there are several, but they probably collapse into three. And all could be overcome, but the possibly the major one would be the short-term impacts of disruption. The disentanglement from our current status and the movement towards some kind of new construct would not be trivial. We heard at the last meeting from just one of our union leaders who flagged some of the labor relations kinds of questions, some of the in-kind support that we receive from the municipality. These kinds of things would need to be negotiated. It would be a substantial effort to move towards a mergers and acquisitions kind of world in terms of taking 3.5 health units and creating one region. So the short-term practical implications, the diversion of energy and effort from frontline work towards an outcome that is unclear troubles me a lot. The second two I've already mentioned. The one would be the potential, the unintended potential, because the expert panel does acknowledge this, the potential to disrupt relationships at the municipal level in the long term. And then Councillor Taylor's observation, the potential to actually lose resources. You know, from a health system perspective, the public health budget is less than 1.5% of the global health budget. And although we're often perceived to be misspending or spending frivolously, really we're a rounding error in the grand scheme of things. The concern that those resources would be slowly diverted to more acute and immediate pressures with very little impact probably but on the treatment side, but significant impact on the prevention side is a very substantial one.
My last question, with regards to the point that Councillor Taylor made about municipal representation, I know he was saying there, I think, talking about removing them, but I see in point 4 about the governance model, it does say, the first one that it does point out is that municipal reps and then provincial appointees, so that's still there. Is that, what is your understanding of that? Because in the report it says that's one of the recommendations that's coming forward.
I have to be careful here. I'm totally agnostic about who sits on my board. I think there's a great deal of advantage to the skills-based and the municipal. But the kinds of issues that I think are buried within that observation, and Councillor Taylor mentioned them, or mentioned one piece of this, is a regional board of 12 to 15 people may include nominally municipal input, but the municipal input from, say, the City of Ottawa would not be 6 out of 11. It would be less than 6 out of more than 11. So that one can reasonably assume dilution of the Ottawa municipal elected officials' influence.
Okay.
Perhaps a bad thing, perhaps not. No, I'm just...
Depends who your board is.
Thank you.
Anyone else on the questions or comments? And just to further the comments that have been expressed on the table this evening, I, as chair of this board, am very much in favor of this position going forward to the ministry, and to say that as a board, we feel very strongly about the new model or suggested new model that may be coming forward. And from day one, my concern has been the fact that where's the consultation? I mean, other than Member Kapoor mentioning this evening the fact that they are sort of bringing this forward without any meaningful consultation with the boards, at least our board anyways, than some of the other boards maybe. So having said all that, I'm going to turn the chair over to Vice President Poirier, because I do have a recommendation 4 that I'd like to add through a motion. So Member Poirier.
Yes, Member Kadri, you have a motion you'd like to put forward?
Thank you very much. And yes, the motion, I'm going to read the whole thing to make it somewhat of a sense at the end for the members in terms of why we're thinking about moving this motion. Whereas the Medical Officer of Health report entitled Ontario's Health System Transformation, Response to Minister's Expert Panel Report, identifies a number of potential impacts that could have implications for the City of Ottawa, and these impacts have also been noted by the Association of Municipalities, the Association of Local Public Health Agencies, and the Council of Ontario Medical Officers of Health. And whereas in respect to the issue of structure and representation, it is expected that the expert panel's proposed amalgamation of health units may result in fewer City of Ottawa representatives at the governance level, with a potential weakening of municipal voice in local public health matters. And whereas in respect of the public health funding model, the impact of the expert panel's recommendation is uncertain, but may result in decreased municipal contributions due to alignment with regional boundaries rather than municipal boundaries. And whereas the City of Ottawa currently provides services to support the Board of Health operation, the proposed governance model may result in disruption of those long-standing services, which may require renegotiation in areas involving human resources and labor relations with potential additional expenses. And whereas in respect of municipal public health collaboration, it is expected that the proposed alignment with the local health integration network boundaries, which are determined by hospital catchment areas, could negatively impact the direct relationship with local municipalities and their departments, school boards, community organizations, and other local entities. Therefore, be it resolved that the Board of Health forward the report to the Ottawa City Council with a request that A, Council approve the report entitled Ontario Health System Transformation, Response to the Minister's Expert Panel Report, and B, subject to Council approval of the report, direct the City Clerk and Solicitor to send confirmation of Council's approval to the Ministry of Health and Long-Term Care. And again, this basically identifies the message that the board is already presenting through if we approve this report going forward. And I just want to emphasize that through the council direction, also a council motion to be presented at council. So having said that, if anybody else want to make a comment on that, I'm open to those.
Yes, thank you, Member Caudry. Are there any comments or questions about the motion before we call a vote? Seeing none, we'll call a vote. So, carried? Carried? Okay, thank you.
Thank you very much, Vice President Poirier. And next item on this would be that there's an amendment to be made to the recommendation 1. And I'll turn the floor over to Member Taylor for that, please.
Thanks very much, Mr. Chair. And with your motion approved, now we come back to the actual report itself and request from our legal staff that recommendation 1, item number 4 on your agenda, says endorse this report in response to the Minister's Health, to the Minister of Health and Long-Term Care's expert panel on public health. Our staff are suggesting we simply replace the word endorse with the word approve. So it would read, recommendation 1 would approve this report in response to the Minister of Health and Long-Term Care, et cetera, et cetera. So it's a technical amendment to address concerns that our legal folks had.
Is that amendment carried? Carried. So now I'll read out the recommendations again for the report, and then we can come back to the board for a vote. Item 1 says, approve this report in response to the Minister of Health and Long-Term Care's expert panel on public health report entitled Public Health Within an Integrated Health System. Recommendation 2, approve that the Chair of Board of Health submit this report to the Minister of Health and the Long-Term Care as part of the Ministry's consultation and write a letter to the Minister outlining the key consideration in the report. And 3, approve that the Chair of the Board of Health, subject to approval of recommendations 1, forward the letter to all Ontario Boards of Health, Ottawa City Council, the Association of Municipalities of Ontario, the Association of Local Public Health Agencies, and local members of provincial parliament. And item number 4, as we added, was the motion. So is that report carried as amended? Carried. Thank you. Thanks, everybody. Yes, Member Cooper.
Just a quick question. The motion that you made, assuming that it passes, I'm not sure if there'd be any problem with that report, council letter also going to all the several people, copied to all the several people that are in this motion?
Yeah, we will carry the process forward as mentioned in the report on the other 3 recommendations and along with the council recommendations going forward. Okay. Anybody else? No? All right, thanks, everybody. And item number 5, Ottawa Public Health application to health, item number 6, West Nile virus. Sorry, it is item 5. Thank you. Ottawa Public Health application to Health Canada for an exemption from the Controlled Drugs and Substance Act. And we got presentation on that too, so we'll hear the presentation.
Chair, if I may, just while Andrew and Kira are preparing, I omitted to mention that Genevieve Cadieux is with us. This is Genevieve's first meeting. You all know of Genevieve, our new associate MOH, but I should have welcomed and introduced Genevieve in my comments, and I didn't, so thank you for letting me do that now.
Thank you very much, Israel, for that, and the floor is yours.
Good evening, bonsoir. I'm glad to be here this evening with Kira Mandrick, who's our supervisor of our harm reduction program, to talk to you about supervised injection services for the interim service that's being provided out of 179 Clarence. Good. At our last board meeting, we received approval to operate an interim supervised injection service within our existing harm reduction program located at 179 Clarence. This approval was to operate for 120 days, which brings us close to the end of January. This was done in partnership under Sandy Hill Community Health Centre's Health Canada application, given that they were the only local agency that already had federal approval in place, and that OPH felt a need to act with urgency based on the overdose data that we were receiving from partners over the summer months. The current Health Canada exemption for our interim supervised injection service has specific criteria in which the current exemption expires, and one of those includes the date in which Sandy Hill Community Health Centre begins to offer supervised injection services at their Nelson Street location. Sandy Hill Community Health Centre is continuing with its preparations to offer these services at its own site. However, it still requires significant renovations, which have not started. And so it remains unknown at this point in time at what point they'd be able to begin operating. That being said, in the event that Sandy Hill opens before this board, meets again in early 2018 to further discuss more permanent solutions for supervised injection services here in Ottawa, OPH would be required to discontinue its services according to the Health Canada exemption. We've had over 550 encounters over the last month. We're actually just have been open one month as of a couple days ago. And we're now seeing between 20 and 30 people per day since we've expanded to 12 hours. So as such, we're seeking board approval to submit an OPH-led application to Health Canada. This would replace the current exemption that is done in partnership with Sandy Hill Community Health Centre. I want to assure you that this is an administrative technicality to ensure that OPH is able to continue to provide its services under the existing model in order to not jeopardize a break in services for current clients. It does not replace my commitment to bringing a more fulsome report to this board in the first meeting of 2018, which will include longer-term recommendations based on the evaluation of our services. It would also be at that meeting where we would include discussions about more permanent solutions for supervised injection services, including the possibility of a mobile van that provides supervised injection services. And we'd also give consideration to the landscape and coordination of supervised injection services within other organizations across Ottawa. As a reminder, our evaluation plan will monitor service utilization for the existing service, as well as 4 distinct stakeholder experiences, which include the client experience, employee experience, community experience, and partner experience. We've begun data collection in several of these 4 domains and are looking forward to engaging with these stakeholders in obtaining feedback on our services. That concludes the presentation. Kira and I are pleased to take questions if you have any.
Okay, with the indulgence of the board, before we go to question, we do have a speaker, so I'll bring the speaker to the table first, and then we'll go to question after. Is that okay? So at this point, I'd like to bring up Mr. O'Leary, Sean O'Leary, who's representing, I guess, the parents this evening. Yes, please, right at that corner. Welcome, Mr. O'Leary, and you have 5 minutes to address the board, please.
Thank you. Thank you, Mr. Chairman. First off, my name is Sean O'Leary. I'm the Executive Director of We the Parents, an organization of many families throughout Ottawa, suburbs, of youth that are suffering or struggling with substance use disorder and opioid use disorder. We would like OPH and the City of Ottawa to take note that we are firmly opposed to OPH's request for a mobile safe injection site unit. We as an organization understand the need for safe injection sites. We absolutely do not understand the need for a mobile one. To my knowledge, there have been 6 teenagers die in our city of an accidental overdose in the past 11 months. I believe 5 of them were from snorting crushed counterfeit pills. The 6th, I'm unsure of their way of taking the drug. If I know of 6, I'm sure there's more. As a rule, our youth in the suburbs of Ottawa smoke or snort their drugs far, far more often than they inject. Intravenous drug use is the last step. We are trying to help our youth before they take that final plunge. Having a mobile injection unit will only encourage and or enable some of our youth to give it a try. Canada prides itself on being a country where all medical treatment is scientific and evidence-based. There is no scientific evidence-based studies to show that having a mobile, safe injection site unit will save lives and or reduce drug use. On the contrary, it may be enabling and or encouraging youth to partake of drugs in a safe environment. Problem is, that safe environment won't always be available. What happens then? The only other jurisdictions that have mobile safe injection units are Montreal, which has only been operating for less than 2 months and only operates in the downtown core, and the city of Kelowna in British Columbia. That one in Kelowna cannot even be considered by the word of it. Excuse me? Yes? Yeah. Oh, sorry, he had his hand up. I thought he had a question.
That's a question afterwards.
Okay, so in Kelowna, the mobile unit parks in 2 locations only, so it's not really a mobile unit. It spends a certain number of hours at one location, then moves to another location for those hours. Even the numbers do not add up. Dr. Levy is quoted saying it would cost $40,100 to operate this unit. Yet in Kelowna, it costs $200,000 to staff the unit, and an OPH spends $75,000 per month to operate a stationary safe injection site with 2 seats, which is the same as a mobile unit. Dr. Israel Levy, the city's medical officer of health, has backed the idea of launching a mobile supervised injection service. To quote, "I've always believed mobile services are the best services to reach people where they are geographically in a community," Levy said at the recent Board of Health meeting on September 18th. Does Dr. Levy just believe that the mobile safe injection site will assist in this crisis, or does Ottawa Public Health have scientific, evidence-based data on which to base Ottawa and the province in making the decision to fund such a unit? With respect to Dr. Levy, we do not think it should be funded based on his own beliefs. If there is scientific evidence to show that having a safe injection unit will save lives and help our children use less drugs, we would be all for it. But I have done hours and hours of personal research and have not found any of those scientific studies done on operating a mobile injection unit. I just wanted to conclude that if that unit is approved and acquired in our city, we will battle and do what we need to do to get it stopped. And if it's here, then we'll do whatever we need to do within legal means to show our city, the province and the country that we are sending mobile vehicles out to the suburbs to allow our children to learn how to inject drugs and to use drugs. Thank you.
Thank you very much, Mr. O'Leary, for your presentation. Have a seat, Mr. O'Leary, because there may be some questions from members of the committee. Councillor Fleury.
Just on a point of order, I do have questions for the delegation, but Dr. Levy, could you confirm that the item in front of us does not speak to any mobile component, and that if or when any mobile services were to be considered, it'd be part of the budget for this year?
Thank you, Chair. So, trying to get my head around some of the absurdity. There is no issue before you today that addresses a recommendation regarding mobile services. There is nothing in the budget that speaks to $41,000. We do not use the language safe injection. We use the language supervised injection services. Part of the reason is for that is the argument that we've heard from a number of people on different ends of the spectrum of how people interpret science regarding whether anything is ever safe. Drinking water sometimes in excess is not safe. So supervised, nothing before you is about safe injection. Nothing before you is about my belief system. What is before you is about my judgment and the judgment of many scientific professionals who work within our organization. I would just note that it sounded to me like there was a threat, and we would obviously bring concerns of action that the citizens might take against our staff. We take very, very seriously, and if necessary, that I would flag that on your behalf for Ottawa Police Services.
Mr. Chair,
it's our time.
Just if I can continue on my questions.
Sure.
For the delegation, so Mr. O'Leary, you're an executive director. Is it a what's the?
Not-for-profit, We the Parents.
And it's registered non-for-profit?
Yes, it is.
So you have a board of volunteers?
We do.
And the delegation you've just given has been an approved board direction?
Yes, it is.
Okay. I would caution the group on a few elements. So I think it's important to speak to a matter that's presented when you come to committee. I would also caution you on creating a divide between parents, because an urban parent and a rural parent share very similar concerns around their youth well-being. And although we are very community-centric as councillors, we are elected citywide, right? Sorry, we're elected in our ward, but we're representative of the city. We're not only ward councillors, we're also city councillors. So when we make decisions, we certainly take pride in what our impacts it might have on our community, but we try to have a lens that is citywide. And I have to share with you that the services that are currently offered by the van go across our city.
We were not discussing what the current services from the van are. I believe it's been reported but in the newspaper, and it's a line item for next year, is a mobile supervised injection site.
I just wanted maybe to.
I don't want this.
I just want to finish my comment, Mr. Chair, if I may. I just have a comment.
Do you have a question, Member Fleury, for Mr. O'Leary?
My question was around the governance model. Now I'm just finishing my comment on the delegation's presentation, if you wouldn't mind.
Okay, thank you.
So further to that, I do think that we have existing services that, as members of the board and members of the professional health team that we have at Public Health, do offer injection services, paraphernalia, so that we can reduce HIV rates, so that we can reduce hepatitis C rates and others. So those are existing, and the data shows that the van goes across the city. So, you know, going in depth and opposing it without having the full data of where our van is currently going, I think is premature. I also think it's, in our world, it's not black or white. There's some gray, and it's important that everything be presented prior to making a full decision. So when the matter is in front of us, let's look at it. We understand that you've taken position. I would ask you to keep an open mind into the issue, and let's look at the facts when it is in front of us. My gut tells me that if it is an important health pillar, which I think it is, that we should have health services, including supervised injection service, in our community health centers across the city, which I've highlighted in the past, and it's been our position for the submission to Health Canada. And that if the needs continue to demonstrate that a van is needed, that we consider that. But I don't believe that the matter is in front of us today.
Thank you very much, Member Fleury. Member Chernyshenko. Okay, thank you. Any other questions of the public delegation? Member Kakish.
Thank you, and thank you for the presentation. And I am intrigued by your position, given how strong of an advocate you have been over this issue in the past year or so. And I can tell you, I personally have a lot of respect for Dr. Levy, and I think most people around this table do as well. And we're lucky to have him here as our medical officer of health. So I don't think you're going to get too far by being here and speaking about him the way you did. But that said, you did your own research and that you didn't present that. So I'm just wondering if you can perhaps email us after, or if you want to speak briefly about the research that you say you did to support your presentation today.
The research is that there is no supervised injection sites that are mobily, other than in downtown Montreal, operating in Canada. So there's very little evidence to base it on, whether it be for Ottawa or elsewhere. And I did not mean, as Mr. Fleury had commented about separating downtown parents with suburban parents. It's more of, the marginalized sector of our population that are sometimes dealing more in the downtown areas in comparison with the suburban youth, which we represent. Maybe I was sometimes I'm involved in a very emotional situation. There's many families I deal with that they're struggling through a great deal. There was a 15-year-old girl in Canada that was mentioned in the papers 3 weeks ago missing, that had been doing intravenous use of drugs. And I guess a lot of is fear coming from us that, yes, we understand the need for having a supervised injection site, but having a mobile supervised injection site scares us. And so when you asked for me to send you homework, the homework was basically spending hours to find that there is nowhere else that really has it. And I don't think that it's right for our youth to be part of an experiment where there's actually a van that can be called to go to various places to help people safely
Mr.
inject
O'Leary,
drugs.
just a word of caution again, as Member Fleury was mentioning, that item is not on the table this evening.
Okay.
Here we are strictly
it was mentioned earlier, so
It was
mentioned in a different context through City Council on the staff recommendation report suggesting about fleet acquisition.
Okay.
But at that point, that recommendation didn't come from this board.
All right.
That recommendation was put forward by the staff, and we will discuss that at that time.
All
So
right.
just caution you on going forward. I do have Member Member Kakish, do you have any other question? Member Taylor, please.
Thanks very much, Mr. Chair, and thank you for the presentation, Mr. O'Leary, and certainly, as Member Kakish said, I'm familiar with your background and the struggles and the travel that you've made to get to the position you're at, and the kind of the personal challenges that your family has had with substance misuse. And I certainly don't believe that you intended to affront Dr. Levy or the staff. I don't think that was your intention. Certainly you're emotional about this issue, as you indicated. I wish we lived in a world where Dr. Levy, everything that he told me I liked, but we don't. And sometimes he tells me things that I don't like to hear. And sometimes, we learn things as a result of sitting around this table that, about our community that, bothers us and troubles us. And we wish that we lived in a different community where we didn't have some of these challenges. The reality, though, is that we do. And, we're not given the option of turning a blind eye. We have to respond to them. I just want to, I guess, maybe ask you, with respect to supervised injection sites, you did make that differentiation between a mobile versus downtown or versus a fixed site type of thing. Has your board taken a position on, are you notionally in favor of the concept of supervised injection sites?
When we first started, there was a lot of back and forth about it, but overall, I mean, as myself as a parent of a daughter who's struggling, you can see the need for them. Yes, so I guess we would be behind them. I think the city's going ahead with one, and and I guess my only concern is, and I think that has more to do with the Champlain Lynn than it does with the Ottawa Public Health, is that too much of our budgeted dollars are going towards overdose prevention and not enough towards treatment or detox, because really 9 months after I first brought it up, still in this city, if you're 16 years old or younger, there's nowhere to detox. And I mean, that's not just Ottawa Public Health, that's the Champlain Lynn, Ontario, but the fact remains you have a 16-year-old child in our city or a 15-year-old child that needs to detox from drugs. There's not one bed in this city available. And so that part of it, I believe we're failing in, but no, I think as Dr. Mark Tyndall, one of the original proponents for supervised injection site in Ottawa, had said, you have to have the treatment and withdrawal services. They go hand in hand with the supervised injection, and whether it's Champlain Lynn or the Ontario government falling down that part, it seems we're doing a lot to protect the people and to save lives, which is very important, but there's that other aspect of it, which is the treatment. And and I think there's been articles even with the OPO site, the pop-up tent, where people have been going and asking for treatment or detox instead of to take drugs, and there's nowhere to be found. And I don't know if that's a situation Ottawa Public Health may probably have on Clarence Street. I don't know for sure, but I think as a whole, as a society, we have to offer treatment and or at the very beginning withdrawal services to help these people get off these drugs, because they're very nasty to.
Sure, and I would argue, I'm not speaking on behalf of the board, I'm speaking on behalf of myself, but I'm in violent agreement with you on that. I think diversion is probably the best and first option, prevent people from getting into substance misuse, and certainly provide supports there so that when people are ready and able to make that transition away from them, that they have a place to go or a program to help them. I was just interested in the middle piece because of your deputation here today. So if you're in favor of or supportive of the concept of supervised injection sites, then my understanding is your chief concern is the viability or the I guess what you perceive to be the danger of having a mobile site that would particularly travel out to the suburbs. Is that accurate?
Correct.
Okay. So if and when that becomes a debate, then I'm sure we'll hear back from you on that when we have that before us. And I want to thank you for coming out this evening.
All right. I want to apologize to Dr. Levy if I said I was just getting a little bit, it agitates me when I talk about it. I mean, there's kids now struggling in Canada, but no means that I mean to disrespect Dr. Levy. I believe in a lot of what he says. I just happen to think in this aspect you're incorrect, and there's no threat. So the threat would be that we would be monitoring it and publicizing the fact that there would be a mobile unit coming out to Canada or in Barrhaven or Orleans or wherever, and not in any other way. We're business people and parents that are with We the Parents, and we're not, we don't try to be, I guess the word activists. We just try to advocate for our children to get them the services that they need, and and as I said, the thought of the mobile supervised injection site scares us.
Thank you very much, Member Taylor. If that's it, Member Kapoor, please.
Thank you, Chair. I'm not going to repeat many of the comments regarding some of the characterizations in the delegation. Just suffice to say, I agree with comments many of my fellow members have said around the table. At the risk of prolonging an off-topic discussion, Mr. O'Leary, I'm going to ask you one specific question. Can you please provide us with any evidence you have that supervised injection sites actually encourage or lead to people using intravenous, not right now, but if you could, by email, forward to us any evidence that you have that occurs, and any evidence that you have that intravenous injection use is not going on in the suburbs of Ottawa. If you could provide us that by email,
well, first off,
appreciated.
I am not going to provide you evidence that safe injections, supervised injection sites don't work. It seems the scientific evidence is leaning towards the fact that it does save lives, and it's looking like it's a necessity. As I stated, there is no evidence on the mobile units because the only one operating is in downtown Montreal right now. So it's hard to get very much evidence, and I think it's only been operating for 6 or 7 weeks. So the fact is that there is no scientific evidence one way or the other on actual having a mobile unit that could be called to different places, as they don't exist. So sorry, I can't supply you with that. As for if you want evidence on what our kids use, I will gladly get the kids to give me a survey.
Thank you very much, Mr. O'Leary, for your presentation for this evening. And if seeing no further question, I will turn the floor back into the board. And I know Member McKenney has a question of staff. So, Member McKenney? Just with staff.
Thank you, Chair.
Actually, Member McKenney, if you can just hang on to your thoughts for 2 seconds, because I do have to ask Member Tilley to move a motion for this meeting to continue past 7 o'clock. Member Tilley.
Be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 8(1)(c) of the procedural bylaw.
Is that carried? Thank you. Okay, Member McKenney.
Thank you, Chair. I appreciate it. I just want to speak on item 5, the application for the exemption at Clarence Street. My colleague, Member Fleury, and I have, I think, in terms of the areas, the wards that we represent, probably have the highest need for what I tend to refer to as supervised consumption services. And the reason I say consumption rather than injection is that often the services being provided aren't just for injection drug users. So I just want to make that clear that, when the vans go out, and I'm not talking about vans, I'm just talking about our van today, but when it goes out and when we see people, whether it's, today it's at Clarence, it will be at Sandy Hill. I look forward to when the supervised consumption service opens at Somerset West Community Health Center, because in that part of the ward that I represent, what we're seeing on a daily and weekly basis is really quite unconscionable for that to be happening in our city without us having a response to it. And we've been slow. We've been slow as a country. We've been slow as a province, and to respond to an oncoming crisis. We've seen it coming for over a year, and here it is. And just the other day, actually, I had a panel discussion on another topic, but one of the panelists that I had was an opioid, somebody who is a regular user of drugs. And, this person lost 3 friends in the last 3 months. As I left that panel, a woman came up to me, a young woman, handed me a a note and said, you know, thank you for caring, but she lost a roommate, you know, about 2 weeks ago. So it's happening. It's happening in rooms in the ward that I represent. It's happening on people's couches. We are losing people to this opioid crisis. So, you know, while I'm happy to see that, you know, 179 Clarence is up and running, and that more and more people are visiting and able to, you know, consume safely, and have people watch them so that they don't overdose, and have, whether it's naloxone or, you know, have the means themselves to help people through overdoses. We need it across the city. We need it in many areas in this city. You know, but certainly I'm, you know, still waiting and anxiously for it to, for supervised consumption service to begin at Somerset West Community Health Center. We have to, you know, the loss of residents and the loss of our neighbors and people's friends has to stop. So I will be supporting this. I am happy that to see that the board is also supporting the recommendation here today, and I look forward to doing much, much more. Thank you.
Thank you very much, Member McKenney. Anyone else? Member Tilley.
Just very quickly, you mentioned it sounds like there's a delay or things are behind schedule at Sandy Hill Community Health Center. Is there any particular reasons you can share with us, Andrew, that you're aware of? Is it construction? Is it other concerns maybe?
Yeah, thank you for that question. So, I mean, I've been in constant conversation with both David and Rob with respects to their services. I don't think it's anything in particular other than the logistical considerations about getting renovations done. So right now they're working on things like tenders and getting bids in for that type of work to take place. Rob was telling me earlier today that that work is advancing. This report and the approval that we're seeking is really it's a technicality to ensure that there's no break in service in the event that Sandy Hill continues to see, you know, if they're not up and running in a timely fashion, and if they do get up and running in a shorter time frame, we don't want to have to discontinue services. You know, so in terms of the specific delays with Sandy Hill, you know, we'd have to get more information from them, but right now it's about renovations. So.
Member Lakin, please.
Thank you, Mr. Chair. Thank you for the presentation. You reported that you've had 500 encounters in the since opening, on average 20 to 30 encounters a day. It's a staggering number. Would you, could you comment what your expectation would be what the penetration level would be? In other words, would you expect that the encounters total or per day would be the same or greater for the other sites once they're opened, and whether this number would be sustained at Clarence? Just based on your experience so far.
Thank you for that question. It is hard to predict in terms of what the other services would look like in terms of service utilization. We're hoping that the Intercity Health and the Shepherds of Good Hope partnership unfolds quickly. They are working on a trailer model that's working out of the Shepherds of Good Hope location, and last I heard they're looking at 8 booths. Is that correct, Kira? 8 booths that would be operating 24 hours a day. Based on discussions that I've had with Intercity Health and SHEPS, they're anticipating good uptake of services. It's hard to know what that would look like. Those would be the types of discussions that we would want to bring forward in February. So when I talked about looking at the service delivery across the different organizations that are providing supervised injection services, that would be the time to talk a little bit more about what we would be seeing in some of those other sites. By that time, Intercity Health would be up and running. We're hoping that Sandy Hill Community Health Center would be up and running, so we would have multiple services running at once, at which point we'd be able to look at service utilization across the different organizations. So not sure if that gets specifically to your question.
Yes, that's helpful. If I could just ask, would you, in the absence of the other sites, would you expect that, again, realizing it's not possible to accurately predict, do you think that this is an under-representation or an under-use, and that with extended availability, that usage may in fact increase?
So I can let Kira speak to it about in terms of what she's hearing from clients, but from what I have heard from clients and from partners is that there's a strong demand for services over and above what's currently being offered through Ottawa Public Health Supervised Injection Services, as well as the Overdose Prevention Ottawa site just down the street. And so we're anticipating that even with the Shepherds of Good Hope up and running and with Sandy Hill, that there's enough demand for those services to continue to operate, and that again, those would be some of the discussions we want to have in February.
Thank you very much, Member Lake. And Member Fleury, please.
Merci, Monsieur le Président. Simplement je suis allé visiter le site que Santé publique opère. Regardez, il n'y a personne qui souhaite aller à une clinique, il n'y a personne qui souhaite se retrouver dans des situations similaires, mais je pense que l'équipe à Andrew a fait son possible dans le contexte de l'application. Je pense que c'est important de souligner que c'est une application record en 21 jours, puis d'obtenir la demande qu'ils font aujourd'hui, c'est prudent. C'est prudent de le faire pour plusieurs raisons. On est dans une situation de manque de coordination globale. Ça ne s'applique pas nécessairement juste à nous. Puis, tant et aussi longtemps qu'on n'obtient pas un élément de stabilité, c'est une mesure très prudente à prendre d'obtenir un sursis de Santé Canada sur le sujet. Attendons qu'Inner-City Health obtienne l'exemption. Attendons que la Côte-de-Sable ouvre les portes. Attendons que Somerset ouvre les portes. Et puis, revenons avec une analyse plus concrète des besoins. Mon instinct me dit, et puis étant dans la communauté, que les besoins sont beaucoup plus grands que ce qu'on observe à notre site, malgré le fait qu'on est capable de répondre à certains des besoins, ce qui est rassurant. On a un enjeu de toxicomanie, on a un enjeu de type d'usage de drogue qui est pan-canadien, mais il semble centralisé à Ottawa. Mais je rappellerai aux membres de la communauté que les plus grands besoins se retrouvent un peu partout en ville, puis qu'il y a des gens qui aujourd'hui utilisent la drogue par injection à la maison, puis qui se retrouvent dans des situations encore plus vulnérables. Donc, il faut garder un esprit ouvert sur le sujet. Et puis, moi je fais appel à la prudence. Et puis, moi, je pense que je le laisserai à ça pour l'instant. Alors, j'apprécie l'occasion de le souligner.
Merci, Member Fleury, pour votre commentaire. Thank you. Coming back, anybody else on this item? No? Thank you. One comment that I will make at this time as the chair of the board, that first of all, I know the public delegation that we heard from this evening is very passionate about his topic and about the concerns that he has raised over and over again, not only with the board but in the community. Having said that, I still feel, and I know for a fact, that nobody on this table or in this city does not respect Dr. Levy and his credentials and his profession going forward. And I know that Mr. O'Leary did try to recant some of his statement during the latter stages of those comments. So having said that, I think first of all, we were dealing with an item that was not on the table to begin with. And some of those comments that did come forward were based on emotion, and we'll leave those comments there as is. And but to support, obviously, not only Dr. Levy, but the medical team that works with Dr. Levy on a day in, day out basis, I also have a lot of respect for them. And I think the decisions that they're putting forward in front of the board and for the board to decide on are valid decisions. And we should respect those credentials and those decisions that we as a board make going forward. So I want to thank everybody for their input on this particular topic, and I'm happy that everybody around the table pretty much had an opportunity to put their thoughts in, either through the public delegation or directly to Dr. Levy and the board and the staff. So thanks everybody, and can we carry this item? Carry. Thank you. Moving on to item number 6 with the West Nile virus activity 2017 season. We do have Andrew Hendricks again on the table to present, along with Dr. Munir Taha for the presentation.
Thank you. So I'm pleased to be here with Dr. Munir Taha, who's an Associate Medical Officer of Health that works closely with our environmental health team, and in particularly with our West Nile virus prevention program. It's timely for us to give you an update on West Nile virus activity for the 2017 season, given that it's our impression that West Nile virus, in contrast to other vector-borne diseases such as Lyme disease, have been flying below the radar for the general public attention. So we felt we had this opportunity to raise awareness regarding both the potential harms associated to West Nile virus, as well as update you on some of the work that we do to prevent West Nile virus infections in our community. So the West Nile virus cycles between specific mosquitoes and various birds, particularly species found in urbanized areas. These mosquitoes prefer to feed on birds, but will also feed on human blood, especially later in the summer, when their preferred targets, such as certain types of birds like American robins, have dispersed after their breeding season. As you can imagine, West Nile virus season is dependent on a variety of factors, most notably weather and patterns. Factors such as rainfall, which leads to standing water and therefore more mosquito breeding sites, as well as the length of the amount of hotter weather we have, can further amplify the mosquito population. The spring and summer months of 2017 is a great example of how these weather patterns can impact transmission. A near record wet spring provided lots of breeding sites, and the warm weather experienced at the end of June and July helped the West Nile virus amplification cycle. And at the end, the second half of summer, the warm second half of summer, kept infected mosquitoes flying for longer periods of time than other seasons. So all that being said, as you can see in the table in front of you and as well as in your report, Ottawa has had the most reported human cases since West Nile virus was first detected in Ottawa in 2003. Similarly, the rest of Ontario has also seen an increase in human cases in recent years. And so 2017 is an example of the swings that West Nile virus can take in the northern fringes and dependent on the weather fluctuations that we see. In approximately 80% of human infections, there are no symptoms. Yet in about 20% of infections, there are symptoms, most commonly flu-like illnesses, sometimes called West Nile fever. And in less than 1% of infections, West Nile virus can cause very serious illnesses affecting the central nervous system. So due to the potential seriousness that I just spoke to, it's important to have a mosquito surveillance and control program in place, and that can be built upon quickly if indicated, depending on the seasonal West Nile virus activity. Because of the mosquito most responsible for transmitting the virus, West Nile virus is primarily an urbanized problem, and property owners are also an important component of a mosquito control program because they must get rid of mosquito breeding sites on their properties. Our surveillance program addresses both mosquito and human populations. We monitor mosquito populations through 31 mosquito traps and 150 surface water monitoring sites to adjust the chemical and biological larvicide applications as needed. Surveillance also surveillance allows not only for feedback to adjust the mosquito control program, but it also allows us to warn the public of increased risk of human illness, often before there are any human cases. In 2017, we treated over 115,000 catch basins across the entire city of Ottawa 3 times throughout the entire season. We also use a variety of communication strategies to increase messaging to the public regarding what residents can do to prevent mosquito bites and also get rid of breeding sites. In 2017, that included 3 public service announcements, extensive use of our social media platforms, and several letters to physicians, other healthcare providers, as well as education to city outdoor workers. Going forward, we're going to continue to implement our West Nile virus prevention program and ensure that we make the necessary adjustments, in-year adjustments based on the seasonal fluctuations, as well as adapting to any unexpected results from our various surveillance measures, as well as continue to enhance public education and awareness as the West Nile virus season unfolds. That's the end of the presentation. Munir and I would be glad to take any questions.
Thank you very much for your presentation. Are there questions from the board? Member Chernyshenko, please.
Thank you very much. I guess I'll make a few observations about this particularly extraordinary year. Is it sort of the start of more extraordinary years? I guess my early comments indicate maybe yes, but and then maybe be a little provocative about the messaging just to see how we might look at this problem. My preamble really is about the fact that, yeah, this was an incredible year. It rained and it rained and it rained and it rained, which is exactly what the mosquitoes want in order to breed. It didn't get so hot that it killed them. And then suddenly in September, when we would feel it was safe to go back in the water, so to speak, if I mix metaphors here, windows open, screens down. Fall is typically when you do all the things that you didn't do because there are too many mosquitoes the rest of the year, and there they were in full number. The sort of the September evenings when people would knock on the door and you'd open the door wide, and then suddenly 20 mosquitoes would fly into the house while the door was open was really quite unheard of. So we saw all sorts of odd circumstances leading to mosquitoes being right at their prime West Nile sort of contracting and spreading time. And on a number of occasions, as someone who spends a lot of time doing outdoor activities in the woods, has a cabin in the woods, I'm often, whether it's for West Nile or for Lyme disease, I'm often conflicted about this whole messaging around keep yourself covered up, don't go out in the woods, keep yourself covered up, cover yourself in DEET, which we all know has got some pretty noxious chemicals in it, and some of us don't really like to put on ourselves. And yet, people are still going to go and take risks because, hey, we like to be outdoors and we like to wear shorts and t-shirts when we can and not hide behind mosquito screens all the time. I guess the question that I'm getting to out of all of that is how much emphasis, or are we regularly revisiting this kind of messaging of protect yourself? It's almost like a message of live in a bubble but have fun, when we know that people aren't going to follow all of those steps. To what degree are we expecting the best of human preventive behavior, and how much is the emphasis on people being able to identify when they have contracted the virus or suspect they do, and then physicians being adequately trained to identify it? That was a very roundabout way of really getting to the question of, humans being humans, we won't always cover ourselves up, and we will still get bitten by mosquitoes. In the end, does it all come back to our family doctors, and hopefully not emergency physicians, to be our front line to say, I think that's what you've got, and here's what we can do about it?
Yes, thank you very much, through you, Mr. Chair, to Councillor Chernyshenko. You have hit the nail on the head that reliance on any one factor, and especially reliance on behavior change in people, is often the one hardest to achieve and to accomplish. And that's why it's very important when trying to mitigate the risk of West Nile virus is to have an integrated program and with its base an integrated pest management program, so that the part of people covering up, or if they have an option to avoid those circumstances where you're more at risk for being bitten, and to use insect repellents, that's the last step. So our program very much tries to control mosquitoes throughout the year where they are most posing the most risk, through the larviciding program especially, and also by reducing sites where mosquitoes breed. Now the city can do that on its own property, but people have a large role to play as well, and that's another behavioral issue there. You also mentioned the need for physicians to be aware, and that was very much our aim as well. We had 3 communications specifically to physicians, so that they would have West Nile virus on their minds. Now, unfortunately, with West Nile virus, prevention still is very, very important, because there's no specific treatment for West Nile virus, and that means when a physician is seeing a patient who has West Nile virus, the therapy can only be supportive, but the disease takes its own course. So this is in contrast to many infections that are bacterial, for example, where there are antibiotics.
Thank you. I guess it really is a challenging one, because as I already outlined, we're going to be human. We're going to want to be outside and to play. And then there are all those cases, as I mentioned, of you open the door and they flew in anyway, despite all of your best efforts. I think certainly one thing that struck home with me, if the stay out of the woods didn't, is the emptying. I've got 2 rain barrels, and when I got those messages in late summer, early fall, I thought, gee, it's rained all summer. It's been an awfully long time since I've emptied those rain barrels and got rid of the water in which they may have been breeding, and that was one piece of behavior. That was the only example of water pooling on my property I could think of, but the fact that the messaging got out, and people who had other cases of pooling water could have taken whatever other measures necessary is good. Thank you. That's helpful to know. It's not reassuring to know that there's no treatment, but helpful to know that really prevention, despite all of those challenges, is 90% of the game. Thank you.
Thank you very much, Member Chernyshenko. Anybody else?
Seeing no other comments or questions, can we receive this report? Receive. Okay, the final item on the agenda is the inquiry that was lifted by Councillor McKinney. So we'll turn the floor over to Councillor McKinney for that inquiry.
Thank you, Chair. I made this inquiry back, I guess now it's going back in June. And the reason I made the inquiry, I know that when it comes to, maintenance and how rental units are capped, that, obviously property standards has the resources and the tools to respond to poorly maintained housing. But I'm interested in what's happening out there. I think that I would like to see us move, or at least, not by us, I don't mean the Board of Health, I mean the City of Ottawa, start to at least investigate landlord licensing. We've got, folks who are living, we already license rooming houses, but, other private rental dwellings. We hear from residents, groups like Acorn who are here this evening have been, advocates for residents of rental housing that is not adequate. And, this, if it's, certainly, if we're talking about, heating or water, that's one thing. It affects you can affect your physical health. But, we're also talking often about bed bugs, infestations, cockroaches, and landlords are not responding properly. I know at Ottawa Community Housing, I sit on the board at Ottawa Community Housing, and it's a challenge, there's no doubt, especially when it comes to pest control, when it comes to bed bugs. And it takes resources, it takes will on the side of the landlord, and we don't always see that. We know that we've got properties in our city. Probably less in Somerset Ward. I deal more with rooming houses, but where landlords are not keeping up their end of the bargain, they're making a lot of money, and rents are very high in this city. It's difficult to get a decent place to live. And the lower your income, the more difficult it is. You can't move. You can't just up and move. It costs thousands of dollars to up and move. I switched cable companies about a month ago. I couldn't believe what it cost me, honestly, just like within my own home. So whenever, when you have somebody that wants to move, that can't live where they are, it's expensive. And I think that the landlords who are allowing this, and this is certainly not all, it's not anywhere near the majority. But there are, areas in the city where landlords have not kept up their end of the bargain, and having bed bugs, it leads to very serious mental health and health consequences, including anxiety, depression. Certainly. If you've got bed bugs, people don't have you to their home, you become isolated, it's embarrassing, it's a horrible thing for people to have to live with. So I made this inquiry so that we could get a little bit of evidence under our belt to be able to move forward as a city, and as for people who are concerned about this, to make a case for landlord licensing. And so I want to thank staff for the response that we got. I mean, there's no doubt that how you live affects your outcomes, it affects your health outcomes, your social outcomes. It makes a difference whether you have friends, you're isolated, if people cannot come into your home or people will not have you into their home because they're afraid that, you live with bed bugs. It's devastating. It's devastating for people, and I think it happens silently. I don't think that we know the extent of it. So I want to thank staff for the response. I'm certainly going to use it going forward to argue, at the city for at the very least for us to do some work to look at what it would take, to license landlords, what it would take to make sure that everybody has got equal protection in where they live, no matter who you're renting from. If you're renting from a high-end, or a landlord who, and that's not to say it's just a high-end versus, less affordable housing. But there are definitely places throughout the city where landlords are not taking their responsibility serious. So I want to thank staff for this. I have one question, and I don't know if there's anyone here can answer it, but you mentioned in the response that you do receive that, and I understand that OPH only has a supporting role here. I never expected a response back that said OPH was going to move forward with licensing. But I wonder if staff could just give me an example of maybe what the most common complaints are that we hear. Is it plumbing? Is it heating? Is it bed bugs? What are some?
I'm just looking over and wondering if Sherry has anything to add, but I'm not seeing Sherry behind the chair. So I can tell you it is actually, we don't get a lot of complaints. They tend to go to bylaw, but it does cross the spectrum. We get inquiries about bed bugs. We get inquiries about, sometimes from landlords about hoarding issues. So it's generally issues where individuals believe their living circumstances have degenerated to a point that their health might be put at risk. And very frequently that's true, though there isn't necessarily a public health risk behind that from the point of view of, potential communicability, for example. So individual health is certainly put at risk in many of these situations. And I think that all of the things that you've mentioned are the types of things that we hear. But I will look to Sherry for confirmation and something more quantitative if we have it at our fingertips.
Thank you, and thank you, Chair. And again, just to thank staff for the response, and it is helpful and certainly helps to make the case for more enhanced protections for all residents and especially those tenants who live in buildings that are not being kept up to the standard that we expect everyone to live in. So I thank you for that, and I look forward to moving forward with this.
Thank you very much, Councillor McKinney, and thank you for your inquiry that you did put back up in June, and I thought the staff's response was a good response, but having said all that, I see Member Fleury has a question or a comment.
Well, it's a further comment. I do support my colleagues' submission and also generally understand the staff response. I do see some challenges to it, and I think it's important that we highlight those. 99% of landlords we have no issues with, but the 1% in a growing population is creating a challenge. And the model of bylaw is generally accepted as a model that works. You, as a tenant, you work with your landlord, it doesn't work out. There's a legal regime where you can call the city enforces its regulations, go out and resolves it. Now, the challenge is this one, is that the low income, at the affordable level of rental, some bylaws aren't quick enough for compliance. So you might be caught in the unit with mold, with cockroaches, with others, so much so that the tenant reports it, and then the compliance period for bylaw is too long. So the tenant exits the condition, moves on to another unit, to another building, perhaps to a different landlord. The problem doesn't go away, but in our city records it does. So then we put another tenant in the same vulnerability. And that's where I think public health could find a way to, I don't think tonight we'll find a solution, but it's food for thought. The bylaw model is there as a reactive model and as a legal means for the city to enforce basic regulations. Now, if we were on the public health to kind of act on the different flank, which is more proactive, what could we be as a community resource to monitor, and I don't know how, I don't want to speculate how even, but to look at some of those measures, not to cover all of the bylaws, but in terms of pest management, in terms of mold, elements that have direct impact on a person's health and a person's well-being and mental health. So I thought that the answer was generally okay. I just want to be clear, but I do think that there was a weakness to provide more of a holistic solution from a health perspective, because we know how important housing is to all of us. And we've seen people in very vulnerable position, and I think, again, we're talking about a minority of landlords, but that minority of landlords, we have to find better tools to get to them.
Thanks very much, Member Fleury, and Member Poirier, please.
I'll just offer a comment that, and I agree with everything that's been said to date, and certainly when I was in my former portfolio, while not perfect, Ottawa Community Housing tried hard. I think the licensing issue is worth looking into, because I would hear stories about other landlords that perhaps were not held to the same standard, but because it wasn't owned by the city, it didn't have the same attention paid to it. So I can say this, that I would certainly support the notion of licensing being looked at. Housing is fundamental to the quality of life, so I think it really is an important issue.
Thank you very much, Member Poirier. Anybody else? Seeing none, can we receive this inquiry? See? Thank you. Turning over the floor to Member Tilley for motions to adopt reports.
Be it resolved that the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, the Ontario Health System Transformation, Response to the Minister's Expert Panel Report, the Ottawa Public Health Application to Health Canada for an exemption from the Controlled Drugs and Substance Act Report, the West Nile Virus Activity 2017 Season Report, and the 2018 Ottawa Board of Health Meeting Schedule Report be received and adopted. And be it further resolved that the report titled 2018 Draft Operating Budget for the Ottawa Board of Health be tabled.
Is that carried? Thank you. Motions of which notice has been given previously. I don't have any of those. Excuse me. Motion requiring suspension of rules for procedure. Seeing none. Notice of motion for consideration at subsequent meeting. Again, there are none this evening. Confirmation by law, Member Tilley, please.
Be it resolved that confirmation bylaw number 2017-5, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health at its meeting of October 30th, 2017, be read and passed.
Is that carried? Thank you. Inquiries and answers. Member Fleury, you have a couple of inquiries?
Yes, thank you, Mr. Chair. I have two inquiries. The first one I title Needle Hunters Operating Hours. Given that injection drug user takes place at all hours of the day and night, could needle hunters expand their operating hours? And the following one is subject OPH interaction with injection drug users. Due to the 179 Clarence Supervised Injection Site, Ottawa Public Health has been interacting with a much greater number of injection drug users. What is OPH doing to ensure drug users have treatment rehab options readily available? Is there a street outreach component? How successful has OPH been in providing rehabilitation options thus far?
Thank you very much for your inquiries, and if you could submit them to our board secretary, we'll get those responses for you. Any other inquiries? Seeing none, can we call for adjournment? Adjourned? Thank you very much. Thanks, everybody.